get us started. I know we'll continue to have people join us as they get a break in their schedule and manage to get on board. But I'm Robert Stiles. I'm the program director for Telehealth Rocks, and we're really excited to have everyone here for today's session, which is the third out of 4 sessions. So we'll have one more session at the end of April. We're really pleased to have you and pleased that we've had such great participation in these sessions and hope you find them really helpful. So wanted to want to go to the next slide. There we go. Well, we've asked everyone, of course, to introduce themselves in the chat. We will keep everyone muted, but you can unmute yourself to ask questions, and please feel free to ask those as well as type those into the chat. I hope you'll keep your camera on, but I know some of you have people coming in and out of the room or various reasons to have that off. We will be sending out completion certificates for continuing education after all the sessions. So we'll send those out just after the April session and that will be for all of the hours that you've completed by participating up to 4 hours. We'll send out all the materials, the PowerPoint, a link to the video and the stuff from the chat after today's session. And we hope that as we have surveys, and we'll have another one coming up at the end of this to ask for your advice and your feedback on how to do this even better in the future. What other types of information you can use as you continue to work with children with medical complexity and other needs in your schools and communities. Next slide. So I'm going to hand off. I believe that Dana Bacula is kind of leading things today, so I'll hand off. But obviously the 3 leaders of sessions are Emily Goodwin from Children's Mercy and Ryan Smith from KU School Medicine and Dana Bacula, who is also with Children's Mercy. So Dana, I'll hand it to you. Really excited to hear what you have to say today.
Great, thank you. Can everyone hear me okay? Great, thanks Emily, I see you're nodding. You can go ahead to the next slide, Christy. So our agenda today, we'll go through a few brief introductions and disclosures. We'll have our didactic presentation followed by a case presentation and group discussion slide. We don't have any relevant financial disclosures to discuss, and we don't intend to discuss any unapproved or investigative use of commercial products or devices. Next slide. And the information and recommendations involving clinical medicine are based on evidence that is currently accepted within the profession and are not medical advice. Next slide. And as Robert discussed, if you receive surveys from us, please give us some great feedback. We really appreciate that, and it helps us to shape our ECHOs in the future. And all of the materials, the slides in the chat log will be emailed to you today after the session. Next slide. And so today is our third of 4 sessions on caring for children with medical complexity across settings. And we will be talking about educational and medical supports. Next slide. So our objectives today are to identify common educational and medical needs for children with medical complexity, to understand the use of IEPs and 504 plans and describe common components involved in their development and implementation, and to recognize the educational needs of older children with medical complexity, including transition and graduation. Next slide. So first, I just want to get us started off with a shared definition of developmental disability, because this is something that is really common and applicable to children with medical complexity. So a developmental disability is a disability that occurs before the person reaches 22 years of age, substantially impacts the person's daily life, and is caused by an intellectual disability or related condition. Next slide. And so we use lots of different terms when talking about children with medical complexity and children who have developmental disabilities. And so on the left is a word cloud of some of those common words that we use in describing these children that can range from, learning difficulties, learning disorders, developmental disabilities, developmental delay, pervasive developmental disorder, lots of different terms, so much so that the Developmental Disability Resource Center has a glossary of developmental disability terms and terms related to services and care for these children. And they defined 702 terms in their glossary alone. So it really speaks to how much language is out there, and also acknowledging that when we're in medical settings versus school settings versus home or community settings, we might use different terms. So just wanted to kind of acknowledge that we may use some different ways of talking about these children and their needs. Next slide. Also, just to speak a little bit to prevalence of developmental disability broadly. So these are data from the CDC in 2014 to 2016 and in school-age children, and show that in 2016 alone, about 7% of children qualified as having some type of developmental disability, which really speaks to the fact that we all encounter these children on a regular basis. Next slide. Among children with medical complexity, there are a few conditions that are relatively common or more common in these children, including intellectual disability, learning disorders, and then ADHD and executive functioning deficits more broadly. So we'll talk a little bit more about each of those, but feel free to speak up with any questions that you have in the chat as we're talking. Next slide. So first is intellectual disability. So children with medical complexity are at higher risk for intellectual disability relative to their peers without medical complexity. And intellectual disability involves impairment in intellectual functioning and adaptive functioning. These children have below average intelligence, they learn new skills more slowly, and the difficulties can range from mild to profound. I also think it's really relevant to talk about the fact that when we think about children with intellectual disability, we think a lot about that intellectual functioning being below average, but we don't as much touch on the fact that adaptive functioning skills are also impaired, such as social and communication and daily living skills. These are things that these children have a lot more difficulties with as well, and can really impact their learning in a school setting.
Good. I'm just grabbing some accoutrements.
Okay, next slide.
Oh, yeah, whatever you need. Thank you. Yeah, thank you for your help, Ability.
For learning disorders are also much more common among children with medical complexity. And learning disorders are distinct from intellectual disability in that it's not the intellectual abilities of the child that are impacted, it's the information processing system. Children can certainly have both intellectual disability and learning disorders, but they are distinct in that way that it's about the learning process. And there are also specific types of learning problems that children can have in specific areas, like written expression versus reading versus mathematics. And these prevent children from learning new skills and using them effectively. And what's really important to know is that among children with medical complexity, about 30% of these children have learning disorders as compared to 5% of children without medical complexity. So again, we really just see that there are a lot of downstream effects of this medical complexity on learning and educational needs of these children, and they go hand in hand a lot of the time. Next slide. We also see that ADHD is more common among children with medical complexity. Many of you are probably familiar with ADHD. We see this in more and more children. This can be things like daydreaming a lot, forgetting or losing things, squirming or fidgeting in their seats, talking too much, making careless mistakes, having a hard time resisting temptation, having trouble taking turns, difficulties getting along with others. And so we see that ADHD is more common among these medically complex children. And again, that's because a lot of these medical complexities can also involve how children's brains develop and grow and process information. And so we can see some of these other things impacted as well in those downstream effects. It is important to note that ADHD can have a couple of different presentations. That inattentive type, or what we formerly called ADD, is where children have the inattention, the difficulties focusing, but don't have that hyperactivity, and then vice versa for hyperactive type. And then the combined type, where children can have both. And the reason we also include this executive functioning deficits more broadly, I'll talk about on the next slide, but it's because children with medical complexity, even if they don't have ADHD, sometimes they have some of these symptoms that we see frequently in children with ADHD, and that's associated with this broader kind of executive functioning deficits that are more common among children with medical complexity. Next slide. And so executive functioning broadly is the ability to focus and provide attention, planning and organizing, initiate and persist with new tasks, engage in flexible problem solving, emotional control, things like that. And what we know about medical conditions that involve neurological processes is that they can put children at higher risk for these executive functioning deficits. And so sometimes we may see symptoms that kind of look like ADHD in these children. It does not always mean that they have ADHD. They certainly are at higher risk and they may, but it's still important for us to understand and conceptualize these symptoms so that when we're planning for the supports and modifications that these children may need to their learning environments, we can really understand where these problems are coming from and what they may be. Next slide. And we compiled a list of just some common medical conditions that you may encounter and what some of those common deficits are. Again, we see that with conditions that have some type of neurological process involved, I think epilepsy and brain injuries are the most abundantly obvious that those impact brain and how brains develop. We see broad things like attention, executive functioning, behavioral difficulties, and many medical conditions have some very specific deficits that are commonly associated with having that condition. But you'll also see as you look through this list that there are a lot of commonalities that any of these really complicated medical conditions you might see will often have some impacts on these thinking and cognitive processes. Next slide. So in switching gears a little bit and thinking about some common interventions that are provided in school settings to address some of these needs that we've been talking about with these various types of developmental disabilities, we think about things like modified curriculum, communication devices, assistive technology, extra time or breaks, therapeutic or pull-out services. Sometimes children will have some time in a general education classroom versus time in special education classroom. For more significant cases, we may consider use of paraprofessionals. And I'm curious what people commonly see with their students, and feel free to put that in the chat. Dr. Goodwin and Dr. Smith can shout those out as we hear what you guys see very commonly as educational supports for these children. But really, we want to make sure that they're always very individualized to the child, to what their specific strengths and weaknesses are, and how we can best support them in that learning environment. Any ones that anybody's seeing in the chat as common educational needs for these children or interventions? I see somebody said all the supports listed. That's great. Well, hopefully visual schedules, special education pull-out services. That's great. Okay, next slide. And a question that we commonly get, right? So we've talked quite a bit about what are some of the common difficulties that these children have and what they're more at risk for. And we've talked a little bit about some of those common interventions that we may implement in the school setting. But then there comes the question of who should and who is evaluating these children in order to determine what those deficits are and make recommendations for the school setting. And commonly, school psychologists are involved, clinical or developmental psychologists in the community, and in some cases, neuropsychologists. So we thought we would just go ahead and give a little bit of background about the training, areas of expertise, and what these various professionals can offer for children with medical complexity to help in decision-making for individual children when considering which providers are going to be ideal for that child. So first, thinking about school psychologists who are a wonderful support to children with medical complexity in the school setting. These are people with doctorate degrees in psychology and development who have a specialized training in working in the school setting. They have expertise in learning and educational problems, and they can offer an understanding of the child's performance relative to expectations and make recommendations based on the specific deficits. So they are truly a wonderful support for these children in school settings. However, school psychologists can run into difficulties with time constraints because they serve so many children who are in need. And so sometimes families or schools may opt to also consult with psychologists in the community who may be able to kind of have a broader evaluation than what can be offered in a school setting based on school constraints. And so community psychologists that are clinical or developmental psychologists similarly have a doctorate in psychology and development. They have expertise in development and learning problems, and they can understand the specific deficits seen and make recommendations on what is helpful for those specific deficits. And then kind of our highest level of acuity provider are neuropsychologists. We all know that neuropsychologists are a little bit harder to come by because we have fewer of them. So they're often used for our most complicated kiddos. They have doctorates in psychology and development, but also have specialized training in brain development and brain science. So they really specialize specifically in children with medical complexity and with developmental disabilities. And so they have a lot of knowledge in the specific medical conditions, the courses of how those medical conditions affect brain development, et cetera. And so they can offer children with medical complexity an understanding between the interaction between brain development and current functioning, and they can make very tailored and detailed recommendations for that child. Next slide. So switching gears a little bit to talk about some medical needs that we may see in schools. We see that children with medical complexity, right, they have lots of medications, and some of those may be needed during the school day. They may have safety monitoring needs. They may need to drink water or stay hydrated or engage in other kind of healthy habits for their medical condition. They may have reduced stamina or fatigue during the day. They may even have symptoms during the day that need to be managed associated with their medical condition. They may have special toileting needs, and they may require tube feedings. Next slide. And so in thinking about interventions that may be common in a school setting, again, feel free to put in the chat if you have any common ones that aren't listed on the slide, or any comments about what you typically see with your children. But common accommodations for those physical health needs may be extra time, water bottles, toileting accommodations. So staff may need to be trained in supporting with catheterization or bowel management, extra breaks if symptoms can interfere with kind of ability to persevere on tasks and fatigue, things like that. We may need staff to administer medications, may need to come up with a sign or signal to communicate medical needs to the school professionals. And in some situations, students may require paraprofessionals. But again, really the focus is on individualizing these supports to the needs of the child. Every child does not need the same thing. Even two children with the same medical condition may need varying and kind of different supports in the school setting. Next slide.
Dana, there was a few comments in
yeah.
the chat of some additional accommodations used to address medical needs at school. So one was social stories with attentive pairing for social interactions. And another was G-tube feedings or modified texture diets is another accommodation commonly seen.
Excellent. Yeah, those are great ones. Okay, wonderful. Well, switching gears a little bit, we've talked about some of the common educational and medical needs of children in school settings. So I want to talk a little bit about the IEP plans and the 504 plans, which are how we actually develop and implement those supports in school settings. But before we talk about that, I want to talk a little bit about the historical context, because I think it's so critical that we really understand where these supports came from and where these interventions came from in order to understand how we have them now and how we build them. So first, the Individuals with Disabilities Education Act, IDEA, is a federal law that was passed in 1975 and authorizes special education for children with disabilities and early intervention services. And so this is where IEPs have come from, is this federal law. Section 504 of the Rehabilitation Act, passed in 1973, is a civil rights law that prohibits discrimination on disabilities in both private and public programs. And this is where 504 plans come from. Next slide. And I'd like to spend a little bit of time talking about the differences between IEPs and 504 plans. Many of us are probably very involved in the development and implementation of these plans, but even as experts, sometimes we forget exactly where the boundaries lie between these two plans or between these two processes. And so IEPs, or individualized education plans, involve a plan for special education experiences, whereas a 504 plan is a plan to remove barriers for children with disabilities. An IEP is an individualized education and related service plan, whereas a 504 is modifications to the learning environment to support the child's needs. For an IEP plan to qualify, a student has to have a disability specified by IDEA Act that impacts educational performance or abilities that require special instruction. Whereas for a 504 plan to qualify is any disability that interferes with the child's ability to learn in the classroom. IEPs are goal focused, whereas 504 plans are accommodation focused. And I think that's a very important distinction. And an IEP is based on educational law, whereas 504 is from civil rights law. Next slide. And common components of an IEP meeting include talking about present level of performance, talking about goals, and we know from lots of research that the most evidence-based way to support goals is by creating SMART goals, so specific, measurable, attainable, results-oriented, and time-bound goals. Often these meetings involve special education and related service discussions, discussing what the child might need in those realms, as well as discussing the need for any supplementary aids, services, modifications, and supports. And I want to emphasize that for children with medical complexity, there may be some of these aids, services, modifications, or supports that require additional training above and beyond what might be expected for someone in an educational setting. And I want to emphasize, do not be afraid to ask for training in these things if you need them. It is really critical that you are well trained in the services you are being asked to implement for both your own purposes, but also for serving the child the best that we can. Next slide. And then for a 504 plan meeting is a little bit different because again, these plans are focused on different things. So in an IEP or a 504 plan meeting, we may discuss areas that are preventing the child from fully accessing the school program, such as a child in a wheelchair who can not get up to the lab table in chemistry, and discussing supplementary aids, accommodations, and supports to support that child and allow them to fully access that learning environment. And again, just want to emphasize not to be afraid to ask for training if any of these aids, accommodations, supports, etc., are something outside of your current knowledge or training background. Next slide. So our team has pulled together a list of quick tips for successful IEP and 504 plan meetings, based on this idea of really working to come together all under one roof and really allow for these IEP and 504 plan meetings to really be a partnership between schools and families and others involved. So first, asking for most recent medical records and evaluations with recommendations, again, to really pull in the medical team's perspective, as well as any other teams or groups that the child is involved in the community, really seeing if we can get updated information from the other people involved in this child's life above and beyond just the family and the school setting. Before the meeting, considering how you might meet the needs of the child using the least restrictive environment, and really having that at the forefront of your mind as you're planning for these IEP and 504 plan recommendations. I cannot emphasize enough how key communication is, and I think this has been a theme throughout our ECHO series so far, that communication with the family, communication with other teams and medical providers is so critical to how we support these children and meet their needs. Involving the family, and as the child gets older, involving the child when that's appropriate as well. We really want to make sure that we're partnering with the family and honoring their expertise in their child. And also, as children reach the age of 14 is when we begin planning for transition services, and we want to be involving children in those discussions so that we can meet their goals. Again, respecting the family and the child's knowledge and autonomy. They truly are experts in their day-to-day life and experiences, and we always want to remind ourselves how critical it is to honor their expertise. Sometimes we as professionals can get really caught up in wanting to get our agenda across or implement these things that we know will be helpful, but we always really need to remind ourselves to pause and honor that family's expertise and their autonomy. Also, it's really critical to talk with the family about how they can use school strategies at home and how we might be able to use home strategies in the school. Again, maximize the supports that we're providing for this child by thinking if there are ways that we can think outside the box and implement strategies in both settings that we know to be successful. And also just a reminder that you may not reach consensus in one meeting. There's often this time pressure, and I know many of you in schools have a lot of pressure on your time and what needs to get accomplished. And so sometimes it can feel like you need to come to a conclusion and come to a decision by the end of one of these meetings, but realizing that especially children with medical complexity, it may not always be possible to reach consensus in just one meeting about next steps and how to move forward. And especially in light of the COVID-19 pandemic, as school settings and educational environments are constantly changing, there may even be needs for more frequent meetings. Next slide. And again, another theme that we've really touched on a lot throughout this ECHO, and from the input that all of you have had in the ECHO, it sounds like this is a real strength of those who have come, is really building positive relationships with families. It is so critical that we have good relationships with these families in order to have good communication and in order to really figure out how to best serve these children and meet their needs. So some common strategies that we use include trying to imagine yourself in their place. Again, it's never really possible for you to truly understand what this family's experience is, but doing the best that you can to really envision what it would be like to be in their shoes and understand from their perspective. Begin with positive interactions and keep them going. So talk about, in addition to talking about challenges and things that aren't going well, talk about something good that's happening, talk about a strength of that child or that family, and really make positive interactions a core part of each discussion. Think about what you want to communicate in advance. Sometimes it's really helpful if we have a lot of information we need to get across or some difficult information we need to communicate. It's really great if we can think about in advance how we want to share that information. Using I statements such as I feel or I'm concerned about to kind of reduce burden and blame of how we communicate information. Setting an agenda or expectations each time you talk so that both you and the family and others involved are aware of what information you need to get through, and know that at the forefront of conversations. A reminder that we all need is to say it's okay that you don't know a piece of information, right? We can always say, I don't know, but I can figure out who does. And last but not least, really be a good partner in identifying solutions. It's so critical, again, that we partner with these families and with other providers in this child's life to identify solutions together. I think that's the whole goal of working with families is to come together and be a good partner. Next slide.
I do want to highlight something that Marsha Burns highlighted, which I think is important around communication. And so we have members of the educational team, but I think one of the benefits of this ECHO is to bring educational professionals, healthcare professionals, and lots of other parties invested in the care of medical complexity together and kind of work through these issues. And she brings up the importance of providing a second copy of the evaluation reports to parents to share with PCP and other team members. I think that's a really good point to highlight.
That is an excellent point. I'm glad that you brought that up. And yeah, Ryan, thanks for interjecting with that. I think, sometimes even thinking about the fact that a family may not have a printer or a scanner at home, or it may be challenging to bring a single copy with them to every different provider, and proactively providing extra copies, encouraging them to share with medical providers if the family didn't think about that at first. That's a great idea to have that kind of communication both ways. I love that suggestion. Great. Well, our last kind of, oh, go ahead.
What's that?
Okay, I'm going to move forward with our last kind of 2 bits of information to get through. And these are 2 areas that we just want to be mindful of with older children with medical complexity, which are transition planning and graduation. So first, transition planning. Students with a disability often require assistance from schools and community partners in transitioning from high school to adulthood. And transition planning is required per the IDEA, and as part of IEPs once a child reaches 14 years of age. This can include transition assessments, child and family participation, involvement from relevant local agencies such as vocational rehab programs, community experiences like job shadowing, and really an evaluation and planning around students' goals for employment, education, self-advocacy, and independent living after they transition to adulthood. And again, this is another area where it's so wonderful to partner with the medical team and partner with others in the child's life, such as considering an updated psychological evaluation to help with transition planning, partnering with medical teams who may also be working on medical transition to adult care. Again, lots of really great opportunities to partner and bring this care under one roof for these children. Next slide. And then finally, delayed graduation. So students with disabilities may be eligible for special education until they're 21 years of age or receive a diploma. So if it meets a student's transition and educational goals, they may continue to receive special education services and be enrolled in school through 21 years of age. So that's just something to be aware of. That is something that some students with disabilities will utilize to meet their goals. Next slide. And we've gotten through a lot of information today. There's a lot to talk about when talking about educational and medical supports for children with medical complexity. But key takeaways from today are that children with medical complexity often have several medical and educational needs in school settings. Collaboration and communication are key when designing IEP and 504 plans. And children with medical complexity benefit from early and proactive planning around transition to adulthood. Next slide. And we have compiled a list of key resources that, again, the slides will be sent out to everyone after today's talk. So you'll have access to all of these links for some really wonderful resources that we've put together. Next slide. And Dr. Emily Goodwin and her team at Children's Mercy gracefully shared their COVID-19 specific recommendations for resources amid the COVID-19 pandemic. And so these are some extra helpful resources when considering medical and educational needs of children with medical complexity during the pandemic.